Good morning, good afternoon, and good evening. It is with great pleasure that we welcome you today for this webinar. Professor Brian Marples is Professor in Radiation Oncology at the Department of Radiation Oncology at the University of Rochester. He's well known for his work in general and specifically for the excellent work performed with the SARRP IGRT system. Brian will be talking today on some of the recent work performed at the University of Rochester with an emphasis on the use of normal tissue models of irradiation, which has generated some really interesting data. So without further ado, over to you, Brian.
Okay, thank you, Tim. My name is Brian Marples, and my aim today really is to give a flavour of the kinds of studies being conducted at the University of Rochester and the Wilmot Cancer Centre as part of the Wilmot Imaging and Radiation Shared Resources, as well as some of my own work from my own laboratory. So before we start, I'd like to acknowledge some people whose work I will discuss today. Carl Johnson and Eric Hanandi operate our SARRP for the Wilmot Imaging and Shared Resource, and also for my group, and they plan much of the treatment strategies and the beam deliveries that are used in many of the studies that I'll discuss today. Angela Groves and Nicole Paris, along with Eric and Carl, conducted most of the lung, kidney and bladder studies that I'll describe later that came out of my lab. I'd also briefly mention some concepts from work conducted by the groups of Kerry O'Banion and Anya Majowski and Scott Gerber, work that was conducted through collaboration or through the Wilmot Cancer Imaging and Radiation Shared Resource, with radiation targeting and treatments planned by Carl and Eric using the SARRP multi-plan system, Muriplan system. So this is really an overview of what I'm going to talk about today, describing some normal tissue and tumor imaging studies that used either CT contrast, fiducial markers, or bony landmarks for radiation targeting, from a wide range of studies using normal tissues or orthotopic tumor models in mice. The rationale for all of these studies was to investigate mechanisms of action of radiation with respect to normal tissue toxicity or tumor response. And I'll cover some bladder studies in more depth towards the end of the talk. So let's start with some studies looking at the effects of radiation on the brain in a murine model. This is work from the labs of O'Banion and Majowski, and also from my lab. We have an interest in defining underlying biological mechanisms of radiation-induced cognitive decline. And in this example, we developed a model for targeted brain irradiation, where the isocenter was placed at the center of the brain, and an APPA for an APPA treatment. A secondary isocenter was placed in the eye socket to avoid irradiation of the eye and the optic nerve. This targeting approach, once it was developed, was used for a more complex series of experiments using a window chamber that was implanted into the mouse cranium. And I'll talk about that in the next slide, but really the purpose of that work was to examine the temporal radiation response of microglia in real time, in the same animal, over time, post-irradiation, using 2-photon microscopy. These experiments used transgenic mouse models in which neurons and microglia constitutively express fluorescent proteins for identification and tracking. So this is that study. The first thing we really wanted to do was to confirm the dosimetry we were getting from the SARRP for these whole brain techniques, because the mouse had a cranial window implant, you can see in panel B here, and the cranial window implant was metallic, so we were concerned about dose. So this shows, figure A shows the timeline of the experimental design. The window chamber was implanted, and it was the first assessment was 3 weeks after implantation and 2 days prior to radiation. Once the brain was irradiated with a single dose of 10 gray, then we measured the response of the microglia with multiple time points post-irradiation. And the purpose really was to measure the death and the recruitment and the movement of cells in the same area of the brain, measured in real time through the window using a custom-built 2-photon laser scanning microscope to image the cortical neurons as well as microglia and dendrites. So here's a picture of the experimental setup on the SARRP. And as I said, our concern was the cranial window was metallic and would that impact the dose response. So in panel C here, it shows CT images in the coronal and sagittal planes, and a blue box shows the extent of the 10mm times 10mm beam used for the whole brain RT. And the regions highlighted in red, they're irradiated, and the regions highlighted in green are non-targeted, and that's shown in panel C for the dose volume histogram from these treatment plans. And in panel E, it shows the empirically measured dose delivered in the indicated areas using radiochromic film. So the film was placed in the midline of the brain and underneath the cranial window, and a single dose of 5 gray was delivered from each side. And the dotted line in this bar graph indicates that we got a target dose matching what we planned from the Murray-Plan system. And the film dosimetry really confirmed that the average dose per beam at the midpoint was accurate within 2%. So this is some of the data. So here we demonstrate whole brain irradiation alters the microglial landscape once we look through the window to give an indication of changes in movement and death of cells on that 2-photon laser scanning microscope. So here we're looking at longitudinal imaging of microglia and dendrites after whole brain RT. And the microscope we use to visualize the movement or death or change of these green EGF expressing microglia or the maroon expressing dendrites. So we can image the same field to look at the movement and death of these microglia and dendrites with time post-RT, and we did that for up to 16 days. And these graphs here demonstrate a change in cell number or persistence of cells in the field, and you can see after radiation we get a change in cell number and a change in location of cells within that field. The cells are recruited to the field or move as a consequence of radiation exposure and inflammation, and then we quantified that in some bar graphs on the right-hand side. So after 7 days, we saw significant changes in microglial landscape, and that was characterized by the apparent loss of microglial cells and a significant rearrangement of the microglial location with time after radiation. And about 36% of the cells were not found in their original location. There was movement as a consequence of radiation exposure. So using this longitudinal in vivo 2-photon imaging, this study really demonstrated the feasibility of imaging microglia and neuron interactions and defined how microglia react to whole brain radiation in the same mouse to define the underlying mechanisms of radiation-induced cognitive decline. And this was really allowed because we could do precise targeting using the SARRP. So switching to another normal tissue example, this time the lung. This is work from Angela Groves using the SARRP with a more complex targeting and dose delivery in a C57 female mouse. We take a CT scan that allows targeting and treatment planning to deliver 3 fractions of 6 gray to the right lung to avoid the heart and the left lung. And the biological rationale of this was to evaluate effects in the targeted lung, the ipsilateral lung, and the off-target contralateral lung. And you can see from the dose volume histograms, they showed the desired dose in the target lung with no dose to the contralateral lung or the heart because of the beam angle and conformality. And the overall aim of this study was to examine the inflammatory response in the irradiated and non-targeted lung. The data demonstrated an inflammatory infiltrate was observed in both lungs, but fibrosis was present only in the targeted lung. And if you look at Angie's manuscript, you can see the role of inflammatory cells and the mechanism of radiation injury in the contralateral and targeted lung. But I don't really have time to discuss that today. But Angie's done a whole range of studies looking at the immune response of cells recruited to the ipsilateral and contralateral lung. We've also started exploring the use of the SARRP to non-invasively assess radiation-induced fibrosis. And in this non-quantified study here, we've got C57 black 6 mouse, so we give a single thoracic dose of 17 gray and compare the response of the lungs using the CT imaging on the SARRP with animals that had not been irradiated. So we're developing an approach to correlate these changes on the CT with histopathology of fibrosis markers. And the aim really here is to define a non-invasive way to allow us to look at fibrosis and see when we should sacrifice an animal to do the histopathology. So this is in development, and I'm sure we'll talk about this later as we go, as this work develops. I'd now like to discuss some development of an orthotopic murine model of rectal cancer in conjunction with targeted short course radiation therapy. So that's 5 fractions of 5 gray from Scott Gerber's group, and this is Taylor Zello and colleagues. And you can see in this image here we have a murine colon tumor cell line that's tagged with a fluorescent marker to allow tumor response to be determined. But the tumor is implanted into the rectal wall, and titanium fiducial markers are applied either side of the tumor to demark the tumor. And the radiation regimen consists of 5 consecutive daily doses of this highly conformal 5 gray beam that's delivered 9 days after tumor implant. So we use the fiducial markers to target the tumor with this conformal beam. And then the output of the study is to measure tumor burden and survival longitudinally with time after radiation, and then compare that tumor response to histology and flow cytometric analysis to look at the recruitment of immune cells and the response of immune cells to this radiation therapy, or this short course of radiation therapy, in this orthotopic tumor model. And the work really established a means to target murine orthotopic models in the rectum, or using titanium fiducial markers with fractionated doses that are clinically relevant. And it allowed us to repeat that dose on a daily basis. And that's described in a whole range of publications from Scott Gerber's group, as highlighted here at the bottom. Some of his more recent work, and this is work by Angela Hewson and Gary Hannon from Scott Gerber's group, showing local delivery of SBRT and IL-12 via mRNA technology to eliminate pancreatic tumors, or pancreatic orthotopic tumors, in a murine model. So in this illustration here, we can see the setting up of the tumor, where pancreatic tumor cells are injected into a mouse and they're luciferase tagged so they can be detected to look at tumor growth. And they're injected here, and we can see by the white arrows 2 titanium fiducial clips that flank location of the tumor to allow SBRT targeting. And the tumors were treated with 6 gray per day over 4 consecutive days, and then finally IL-12 was injected. And the study showed that a combination of SBRT delivered using the SARRP and targeting by these fiducial markers in combination with IL-12 was more effective than the individual treatments of radiation or IL-12. And this is shown here in terms of primary and metastatic tumor burden based on fluorescence with time. This is the combination treatment, and you can see a smaller tumor compared with controls or radiation and IL-12 alone. And this is survival going out to 150 days in this pancreas tumor model. And we see survivors for animals that were treated with radiation and IL-12 using this fiducial marker. So it established a really nice model to look at metastatic disease. So I'll now switch to look at work in radiation-induced bladder toxicity. And really, this is elucidating the role of renin-angiotensin pathway in the development of hemorrhagic radiation cystitis. So hemorrhagic radiation cystitis can be a severe and life-threatening complication after pelvic radiotherapy for patients treated for prostate cancer. About 5% of patients develop severe cystitis, and 10% develop mild or moderate symptoms. And they may seem small percentages, but there are 3 million prostate cancer survivors in the US, so we see a large patient population. And the principal molecular targets for radiation cystitis were unknown. But a large genome-wide association study conducted by Sarah Kearns when she was in Rochester identified SNPs in the locus of the angiotensinogen gene, and this is part of the renin-angiotensin pathway. And SNPs in this AGT gene correlated with patient-reported outcomes following prostatic radiation therapy. And angiotensin its signaling effects affect radiation-induced vessel injury and radiation-induced fibrosis. And angiotensin-converting enzymes, inhibitors, have been demonstrated to be radiation protective in other studies in the kidney and the lung. So we tested the hypothesis whether renin-angiotensin modifying drugs had a radiation protective effect on the bladder, and we tried to determine the mechanism. So angiotensinogen encodes angiotensinogen gene, which is part of the renin-angiotensin system and precursor for Ang1. And Ang1 is cleaved to Ang2 by the angiotensin converting enzymes, or ACE. And Ang2 binds to its receptors to regulate tissue inflammation and vascular networks. And in Sarah's patient cohort, she demonstrated that those patients that were taking ACE inhibitors showed a strong protective effect against radiation cystitis. So radiation cystitis was only seen in 4.8% of those patients taking an ACE inhibitor during RT for another cause, compared with 16.5% of patients not taking an ACE inhibitor. So this really suggested that we should be investigating ACE inhibitors in a mouse model to determine the mechanism of action. So we looked at two inhibitors of the renin-angiotensin pathway, captopril and lisinopril. And lisinopril has better bioavailability. So this is our simplified RAS pathway. AGT encodes angiotensinogen, and as part of the renin-angiotensin system and precursor to Ang1. Renin converts angiotensinogen to angiotensin 1, and ACE inhibitors convert that to angiotensin 2, and that affects downstream signaling with its receptors AT1R and AT2R. And this regulates tissue inflammation and vascular networks and can affect inflammation and fibrosis. So this is our working hypothesis. So if we look at focal bladder irradiation using the MORIPLAN image-guided system, we didn't use fiducial markers, we didn't use bony landscapes, we used Visipaque, a contrast agent. So this is delivered to the mice via retroorbital injection, and then we can measure the deposition of that contrast agent in the bladder here, and here we can identify our bladder, and then we can target that with a conformal beam, and here we can see the bladder targeted with our conformal beam, and then the spine and the kidney with red and green here to generate a dose volume histogram, so showing we get our desired dose in the bladder with minimal or no dose in the kidney and spine, those non-targeted surrounding normal tissues. So we used male mice because it was a prostate cancer study. We gave radiation and ACE inhibitors, either captopril or lisinopril, and they were started 5 days prior to RT, and they were carried on for the duration of the experiment. Animals were either given 30 gray single dose with captopril, or fractionated 8 gray times 3 plus captopril, or 10 gray times 3 plus or minus lisinopril. And you can see the targeting approach here for those beams that were used to cover the bladder. If we now look at some of the data, in this assay we measured micturition over a 2-hour period. for mice individually housed. And this was conducted for a range of time points post-RT. And here you can see, for example, of an animal that was put in a cage and micturition measured for 2 hours, and we can see 3 urination events here. But if we irradiate with 30 gray and measure 15 to 20 weeks after radiation exposure, we can see a change in the pattern of micturition. We see more voiding and smaller volume voids as calculated against a standard curve. And then we can plot the mean volume of individual voids and the mean number of total voids from the whole population, even though it's assessed per individual mouse, against time, dose, and whether they had a vehicle or capsicle treatment. So in this first graph here, you can see for animals between 3 to 8 weeks or 15 weeks, given radiation and vehicle, we can see a defined number of voids over that 2-hour period. If we give captopril, we say a similar number. If we give 30 gray radiation with 8 to 3 weeks later, we see similar effects to untreated animals. But once we get to 15 weeks, these later time points, we see a significant drop off in the number, in the volume of individual voids. But if we give captopril to animals that are irradiated, we restore back to baseline levels. So the captopril seems to be protecting in the sense that it's allowing or returning the number of voids back to an unirradiated animal rather than matching what we see after 15 weeks. And if we look at the total number of voids, we see similar levels in animals that are not treated, but when we irradiate with 30 gray, we see an increase in the number of individual voids. And again, if we give captopril 5 days prior to RT and maintain throughout the experiment, we can see a return to baseline levels. So the captopril seems to be protecting against the increase in the total number of voids in this assay. So that's after a single dose of 30 gray, which lacks some clinical relevance. So we do 8 gray times 3, and we see a similar pattern looking at the volume of individual voids. If we irradiate and measure 15 weeks later, we see a reduction in the volume of individual voids, indicating that the mouse is urinating more frequently with smaller volume. And if we look at the number of small voids, we see after 15 weeks a large increase in the number. But if we give captopril, we see some level of protection similar to baseline levels, both on the number of small voids and the volume of individual voids. And this allows us to suggest that captopril protects against radiation-mediated bladder dysfunction. And this was reported in a publication in 2022. And this is data from that publication, or redrawn. Just looking at urothelial thickness for animals at 1 week or 20 weeks following a single dose of sham irradiation versus a single dose of 30 gray. And you can see after radiation here in the red bars, after 30 gray, we get a reduction in the width of the urothelium, and that's somewhat preserved by delivery of captopril. So we get some preservation of urothelial thickness. And this image here, looking at trichrome stained bladder, and we're measuring the response of the tissue layers in that urothelium and muscle layer. So if we then look at bladder toxicity after lisinopril, which has got a better dose delivery, here we can looking at void volume and frequency for animals that had no treatment at a radiation treatment of 10 gray times 3. We see a reduction in void volume that's preserved by the presence of lisinopril. Likewise, we see an increase in void frequency following 10 gray times 3, and this is reduced by the presence of lisinopril. So this ACE inhibitor seems to protect the bladder in terms of a functional assay for void volume and void frequency. And we can also measure EVs in the harvested urine as a biomarker of toxicity. And this is EVs in urine for unirradiated animals. If we irradiate with a single dose of 10 gray, we see an increase in EVs in the urine 1 week after treatment. And if we give lisinopril 5 days before that 10-gray dose and then monitor and assess EVs 1 week after treatment, we see a reduction in EVs. So maybe the presence of EVs in the urine is a biomarker of function following radiation injury and the efficacy of these ACE inhibitors to protect the bladder against radiation-induced function. So now we're looking at the mechanism of bladder toxicity, looking at the recruitment of macrophages to the bladder. And we're staining macrophages with 4F80. This is the brown cells here you can see in the bladder wall, and they accumulate in the bladder 30 weeks after RT. But if we give the treatment with ACE inhibitor lisinopril, this prevented the accumulation of macrophages in the muscle layer. And we've quantified this on the right-hand side. We can see macrophage numbers in the muscle layer increases after radiation, but if we give radiation and an ACE inhibitor, we see fewer macrophages in the muscle wall. So at later time points, it seems to be that macrophages in the muscle wall is really driving this radiation-induced toxicity that correlates with our functional parameter of micturition we've just seen earlier. And this seems to be distinct from the effect we're seeing in the urothelium. If we look at the mechanisms of this and we look at trichrome staining showing thickening of collagen around the vessels between the urothelium and the muscle 30 weeks post-RT, here we can see a reduction in this trichrome staining following lisinopril treatment. And lisinopril treatment diminishes radiation-induced collagen thickening. And we can see quantification of the collagen deposition measuring the width of collagen between the vessel and either the muscle or the urothelium layer, and lisinopril significantly reduces deposition between the vessels and the muscle layer. And you can correlate the collagen width with the number of macrophages both in the muscle and the urothelium. So this suggests or indicates maybe that the macrophage accumulation in this tissue is one of the underlying consequences of radiation-induced toxicity that leads to this change in fibrosis that then leads to this change in micturition pattern. So to conclude this brief discussion and description of what we're doing with our SARRP at the University of Rochester and Wilmot Cancer Centre, we've been successfully able to target a range of normal tissues using different size collimated beams and also using a variable collimator for the bladder work. We've done this using contrast agents or using bony anatomy, and we've demonstrated success with single dose treatments or repeated treatments Monday through Friday or 3 days a week using this bony anatomy or contrast agent. With Scott Gerber's group and the shared resource at Wilmot Cancer Centre, we've demonstrated with our SARRP that we can successfully target orthotopic tumours, either in the pancreas or in the colon, using titanium fiducial markers. And this is either after a single dose or repeated treatments, a short course radiation therapy, 5 gray times 5 or 6 gray times 4. And that has demonstrated difference in outcome in terms of tumor response and radiation. And we've confirmed the dosimetry that we're getting from our system of the Muri plan using film dosimetry in complex setups using a window chamber in the cranium of a mouse. So we're looking at dosimetric methodologies to confirm the output for Muri plan. So I'd like to finish there and take questions if there are any. Thank you very much.
Thank you very, very much there, Brian. That was a fantastic presentation as ever. We do have some questions that have already come in, so we'll address them in a second. But I'll just tell everybody again that if you do want to ask questions, you can do this by typing them into the question panel, which is on the GoTo GUI. And also, we will be emailing you a copy of this webinar presentation at some point in the next few hours or the next day or so. So with that in mind, I'll come to the first question, which is quite an interesting one. So in the microglial, in the neuronal remodeling study, you talk about looking at cognitive dysfunction. Could you outline what tests you did to measure the cognitive dysfunction of the mice, and also if you have envisaged a behavioral analysis as well?
Okay, well, thank you for that question. It's part of an ongoing study, and Kerry O'Banion's lab has been measuring cognitive decline using a range of tests, either a range of tests not in the mouse population that had the modified window. The cognitive tests are done on different mice, and they irradiate them, they wait a time point, and then they run a panel of novel object recognition tests. And for the window chamber, we do a separate cohort of animals and we irradiate those, and then we correlate changes in cells and cell changes with the previously measured cognitive function in a different cohort of mice. And the rationale for doing that is that the animals have a window chamber in, and that's implanted, and we measure over 3 weeks, and that's not really appropriate to do long-term cognitive decline. Mm-hmm. And yep. Assays of cognitive decline while they have a window chamber in.
Yeah, that makes sense. Rather an observation than a question, quite a good observation here, is in the PDAC tumor model, you're essentially seeing complete remission after 150 days in the dual treatment. So the study, did you observe any longer time points? Because that is actually quite remarkable.
So that is not work out of my lab, that's work out of Scott Gerber's lab. And as the question indicates, that you would expect that most tumors would lead to animal sacrifice way before you get to 150 days. But in that study, if you look at the survival graphs, and I listed the reference on the slide, they get a half of the cohort through 150 days, which is remarkable and demonstrates the efficacy of this 6 gray times 4 with the IL-12 that's given with microRNA technology. So it really demonstrates the efficacy. And if you don't give the combination treatment, you end up with animals being sacrificed 30 or 40 days because of tumor burden. So it's a combination of radiation driving tumor antigens, which are then responded, which drives the immune response, and we get an enhanced cell killing with that IL-12 on top of the radiation damage that's caused by that 6 gray times 4. But I agree, it's a remarkable observation.
It is fantastic. Again, another observation and possibly a question here is, what's your rationale behind 30 gray to the bladder?
So that's a really nice question. And our initial rationale was to develop a model and observe bladder toxicity in a time frame and develop some assays to assess bladder toxicity. So we started out with 30 gray. We selected 30 gray because prior studies from a whole range of other investigators had used that as a baseline. So we selected 30 gray to compare our data with that baseline from other investigators, and also to ensure we've got sufficient toxicity to develop our urination assay and other assays that are described in the paper that I didn't talk about today. But we recognize that a 30 gray single dose is not clinically relevant. So we then adopted an 8 gray times 3 regimen, or a 10 gray times 3 measurement, to be more clinically relevant, to give a lower dose but a fractionated lower dose. And then we looked at the assays that we developed with a large single dose to demonstrate bladder dysfunction after those lower fractionated doses.
That's great. And as a follow-up to that is, obviously the work on the bladder does seem incredibly clinically relevant. Are you planning any next steps for this?
So the bladder toxicity project is an interesting one, because the observation that EVs in the urine, so these extracellular vesicles, are released into the urine at the end of treatment, are suggestive or predictive of radiation toxicity. Mm-hmm. So we demonstrated that in a mouse model, but in a human population that we've now published with Yifan Li and Sarah Kearns, they took urine from a human population prior to treatment, and then following a standard course of radiation therapy for prostate cancer, they took urine a week after completion of treatment, and then compared the change in EVs pre-radiation to those post-irradiation. And they demonstrated in patients that developed hematuria, so a radiation-induced toxicity to the bladder, they had a different EV profile than those patients that didn't develop hematuria. So this change in EV profile may be used, or is suggested to be used, or once fully developed, could be used as a marker to predict which patients will develop hematuria after prostatic radiation. So we're really excited that this EV change could translate fairly readily to the clinic. So you'd ask patients to give urine before treatment, you'd take patients' urine after treatment, you'd measure the EV levels, which is somewhat of an indicator of urothelial damage after the radiation, and then you follow the patients for 2 to 5 years and ask them to report changes in urination, and then you correlate those changes in urination with changes in EVs that you've measured in the lab. And the preliminary data we've got so far suggests this would be a good way to predict who will develop toxicity, so you could follow them more closely.
Okay, so it is particularly quite a long-term way to study the follow-up there.
Yeah, and it is a long-term study, because prostate cancer survivors, there's 3 million in the US, or more than 3 million in the US. Most of them don't develop severe toxicities, but a good proportion develop bothersome toxicities, or toxicities that cause a lot of problems with urination. And even though the percentages are small, the number translates to a large number of patients, and there are no real interventions that could be given to reduce this. Hyperbaric oxygen is one intervention that's been used to reduce radiation-induced bladder toxicity, and it's effective. There are limitations. Hyperbaric oxygen is not widely available. A lot of patients have got comorbidities that mean that they can't be treated with hyperbaric oxygen for a range of other interventions that are nothing to do with their prostate cancer or their prostate cancer treatment, but they don't tolerate hyperbaric oxygen. So that is one method, but it's not widely applicable. We're hoping that ACE inhibitors, or treatment with ACE inhibitors, would be a more widely acceptable way of addressing radiation-induced bladder toxicity.
Okay, cool. And then as a follow-up to this one, specifically on bladder toxicity, is what do you think is the mechanism behind the radiation-induced damage to the bladder?
So we don't know the answer to that question fully, but we have data that suggest that we are seeing radiation-induced inflammation. That leads to changes in vascular effects and the recruitment of immune cells, and that leads to the production of fibrosis. And critical to that mechanism are the recruitment of macrophages and the inability of the inflamed tissue to eliminate those recruited macrophages. So we think it's something to do with macrophages and recruited immune response.
Okay. And kind of a nice question in general, I think, for all of these studies is, how relevant do you think gating would be to account for movement of the target tissue?
So that is an interesting question, because certainly for the large single dose in the bladder, 30 gray, we're irradiating for quite a period of time. For the fractionated doses, less so, and certainly for the 5 gray in bladder studies, less so. But with these experiments, the animals are anesthetized with isoflurane, so they're out on the bed, and therefore there's little movement because of that. There is obviously some respiration, but in the studies we look at, we don't see much movement from respiration, given the size of the field and the size of our target.
Okay, so if you've got to compensate for the motion of the animal with a slightly larger field, you'll
Yes, you could do that, but these animals are anesthetized with isoflurane, and once they're down, they're down. It's just respiration changes.
Yeah. Now the questions are still coming in, so I will try and get through these, but does the RAF pathway explain pathophysiology of lung damage due to RT?
So you could argue the same that applies in any late responding normal tissue like the bladder, the lung, and the kidney. We're seeing changes in vasculature, we're seeing deposition of fibrin leading to fibrosis. And renin-angiotensin system is something that's involved in that vascularization response following radiation. So possibly yes. And we could also indicate that ACE inhibitors have demonstrated efficacy in the kidney, and they have demonstrated efficacy in the lung from a whole range of studies, from a whole range of labs. So if we consider those things together, then maybe we could say, yes, it does.
Cool. And I'm just going to finish up with one final question, and this is more of an opinion, is because you showed two nice examples of contrast enhanced imaging and also fiduciary based imaging and targeting. Do you have a preference?
Do I have a preference? Well, I think for the contrast, it's retroorbital injection, and you're limited to the number of times you can give that to a mouse per week, because we need it every time we image. For a fiducial marker, once it's implanted, then you've implanted it, and therefore you use it every day without any concern about injection of contrast. However, the fiducial markers have to be surgically implanted. As you can see from the image, I think that's Gary Hannon's work, with that image, you have to do surgery, implant the tumor cells into the pancreas, then put on the fiducial clips. So it's a surgical procedure. But once it's done, you can then irradiate as many times or frequently per day as you like. So probably the fiducial marker is the way to go, but that's not appropriate if we're doing normal tissue and we're looking at inflammation and we don't want a surgical response to inflammation. So contrast will be a better option. So it's horses for courses. You take your choice, the fiducial marker or contrast, depending on what you're investigating. Tumor work, maybe fiducial markers because you're doing more treatments. Normal tissue, maybe contrast because we don't want that inflammation.
Fantastic. We do actually have a couple more questions coming in, but I think what I'll do is we'll address these offline, because I think we're getting into the detail here. But I think
you can hit me with them, Tim, if you want.
Right,
unless
we'll keep going.
Yeah, go on. I think keep going.
We have time.
Yep.
Clinical correlations from patients receiving radiotherapy would be useful. Has this been examined?
So for the bladder toxicity with the prostate patients and the GWAS, correlating changes in genes to radiation toxicity in the bladder has been demonstrated. Sarah Kearns has got a whole selection of publications which you can track through PubMed demonstrating correlations between patient-reported outcomes and changes in SNPs from a whole genome-wide study with 4,000 plus patients. So yes, correlations have been made, and those correlations that she discovers in her human population really drive the hypothesis and the rationale for some of our mouse studies. But in our mouse studies, we can then modulate and give different drugs and different treatments that she's not able to give in this patient population. And once we've defined the response, it gets translated back to the human population. So correlations between patients are important to drive the questions we ask with mice, and then hopefully we translate back to the patient. And in the bladder toxicity with EEVs, we're starting to do that.
Okay, yeah. And then the follow-up question to this is radiation therapy damage to lung in patients receiving, not receiving ACE inhibitors.
So we do know if you irradiate lung cancer patients or patients treated for breast cancer or esophageal cancer where the lung's in the field, we do see some pneumonitis and fibrosis and toxicity. And that restricts the dose that can be given to those patients. So it's radiation sensitive tissue that defines really the dose levels. We haven't done any ACE inhibitor work in lung animals yet.
Okay, so to be seen.
Yeah.
So that's the last of the questions. So Brian, just want to say, actually, no, it's not. You've started something now.
Okay.
We'll keep going. Age also has an effect on bladder, how radiation affects the bladder, or how does age correlate to the effect of radiation or the damage of radiation in the bladder?
That's a really good question, and it's a question we struggle with every day. For a lot of our studies with long-term time points, when I'm looking at beyond 20 or 30 weeks, we generally start with a younger animal because we're going to carry them out for 30 weeks. But we are cognizant that it is a young animal. Should we be doing studies in older animals? Yes, we should. Getting hold of those older animals is kind of challenging. We do have some studies, but I've not presented them today, where we've had an aged cohort of animals. And when I say age, they're up to 30 weeks before we've treated. And I didn't show those data because they are in female mice, and the data for the bladder I was showing was male mice because that was rationale for that was a prostatic project. But we do have age data in animals, females, and we are analyzing that data at the moment, and hopefully we'll be able to comment on that in due course. So comparing old with young in terms of bladder toxicity, but I don't have any data that I'm able to show at the moment.
Brilliant, Brian, thank you. And I'd say thank you to the audience for quite an extensive question session. Appreciate those coming in. So, I mean, it's great to see the work that you've done, and it's great to see that there's obviously a lot to do in the future. So from Extral, we just want to say thank you very much, Brian, for giving such a brilliant webinar today. And I hope you have a wonderful rest of your week. And same goes to the entire audience as well. So thanks to everybody, and we hope to speak to you all soon.
Thank you for your attention, everyone. I appreciate it.